Senator Rocky Adams, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Neal, Senator Nemus,
Present.
Senator Thomas, Representative Blanton,
Present.
Representative Burke, Representative Fleming, Representative Lockett,
Here.
Representative Riley, Representative Sharp,
Present.
Representative Stevenson, Representative Petrie, Vice Chair Howell, Co-Chair Storm,
Here.
and Co-Chair Bowling.
Here.
Thank you.
Okay, we are duly constituted to do business. The first item on our agenda is the approval of the minutes from June 13th, 24. Do I have a motion? Motion.
Second.
We have a motion and a second. All in favor, say aye.
Aye.
Any opposed? Ayes have it. Minutes are adopted. At this time, we would invite Jeremy Skinner and Jacob Blevins to present to the committee. Thank you all. Please identify yourselves for the record, and then you may proceed.
Good afternoon. I'm Jeremy Skinner, and this is Jacob Blevins, and we are both analysts for the Legislative Oversight and Investigations Committee. We're here today to present a summary of our most recent evaluation of the Kentucky Child Fatality and Near Fatality External Review Panel. The panel was created by executive order in 2012 and codified the following year with the passage of House Bill 290. Per statute, which is 620.055, the panel is required to conduct comprehensive reviews of child fatalities and near fatalities reported to the Cabinet for Health and Family Services and that are suspected to be the result of neglect or abuse. The panel documents its case reviews in an annual report, which includes findings based on those reviews, along with recommendations for system and process improvements. Statute requires our committee, LOIC, to conduct annual evaluations of the panel's operations, procedures, and recommendations. This year's evaluation focuses on the panel's implementation of recommendations from last year's LOIC evaluation, the panel's compliance with statute and the development of its findings and recommendations, and finally, the panel's operations and procedures. This year's evaluation has 3 finding areas, 1 matter for legislative consideration, and 3 recommendations. At its August 2023 meeting, the Legislative Oversight and Investigations Committee adopted 5 recommendations, and those recommendations covered a relatively broad range of issues, including the panel's case management system, its budget and expenditure procedures, its procedures following up with agencies, and the development of its findings and recommendations in the annual reports. In our first finding area, we focused on the panel's implementation of those recommendations over the past year. Overall, we found that the panel took action on 4 of the 5 recommendations from last year's evaluation. Our first recommendation from last year's report was related to ongoing issues that the panel was having with its existing software applications in its pursuit of a new case management system. We recommended that the panel work with officials from the Commonwealth Office of Technology along with Justice Cabinet budget staff to explore options that would allow the panel to use one software platform for case storage, review, and analysis. In the years since our last report, the panel worked with Justice Cabinet budget staff and submitted a budget request asking for additional funding for a new case management system. House Bill 6, the executive branch budget bill for 2024 through 26, subsequently included $200,000 in one-time funding for the panel for the procurement of a new case management system. The panel worked with both COT and private vendors and voted at its May 2024 meeting to have COT design and build a new case management system for the panel, and they expect to have the new system in process sometime in fiscal year 2025. Our second recommendation from last year's evaluation was related to the panel's administrative attachment to the Justice Cabinet. In 2014, the panel and the Justice Cabinet entered into a memorandum of understanding which outlined the panel's independence from the Cabinet and established, among other things, the panel's budgetary and expenditure procedures. Last year, we recommended that the panel and Cabinet update the 2014 MOU to reflect current budget and expenditure procedures. Last month, the panel and Justice Cabinet finalized a new MOU to further define the relationship between the two parties. The new MOU is effective through June 2026, and it outlines the roles of each party with regards to staffing and administrative support, as well as articulating the panel's budget and expenditure procedures. A review of the panel's actions since 2022 shows that the budget and expenditure procedures outlined in the new MOU accurately reflect the actual procedures used by the panel and Cabinet currently. For example, as outlined in the MOU, the panel submitted a budget request to the Cabinet last year in the months leading up to session, and the Cabinet subsequently included that request within the Cabinet's overall budget request. And as you can see here, in addition to receiving the non-recurring funds for the new case management system that I mentioned earlier, the legislature also increased the panel's annual allocation from $420,000 to nearly $600,000. The increase in funding has enabled the panel to hire an additional full-time case analyst, along with continued part-time support from an epidemiologist. Our third recommendation from last year's report was related to changes that were a result of Senate Bill 97, which was passed in 2022. That bill had several changes in it, but one of the major changes was related to the recommendations in the panel's annual reports. The new legislation requires the panel to identify agencies responsible for implementing its recommendations and then to notify them in writing. Agencies are then in turn required to provide written responses to the panel. We recommended that the panel develop procedures for following up with agencies responsible for implementing the recommendations in the panel's report. While the panel staff have indicated they could follow up with non-compliant agencies, they can only do so if the panel itself directs them to. But as far as having procedures for this issue, there's been no action on that as of yet, but that will be addressed later in the presentation. Our final two recommendations from last year's evaluation were related to the findings and recommendations in the panel's annual reports. We encourage the panel to continue ensuring that the findings are based on data presented in the report and the recommendations are actionable, targeted, and directly related to the findings. We also recommended that the panel organize the information in its reports so that each finding area is clearly articulated and related to corresponding recommendations. Our review of the panel's most recent annual report, its 2023 report, shows that all of its findings are supported by evidence, data, or analysis identified within the report. Additionally, all 25 of the panel's recommendations are actionable and targeted, and all address the concerns expressed within the corresponding findings. Further, the organization of the panel's 2023 report generally provides distinct finding areas that clearly correspond to the associated recommendations.
Our second finding area relates to the panel's statutory requirements, which cover topics such as panel membership and appointment, meeting requirements, and reporting requirements. The panel has continued to meet its statutory requirements. However, finding area 2 identifies a few aspects that may be improved related to membership vacancies and agency notification of the panel's recommendations. Statute requires that the panel include 5 ex officio non-voting members and 17 voting members. Of the 17 voting members, 4 serve based on their position or title, while the remaining are appointed by either the Attorney General, Chief Justice of the Kentucky Supreme Court, or the Secretary of State from a list of 3 nominations provided by entities specified in statute. The panel members appointed by the Secretary of State serves as the chair of the panel. Table 2.1 on page 6 of the report shows the panel's makeup. Since the writing of our report, the 2 vacant panel positions have been filled. For the first time in several years, there are no vacancies on the panel. Other than a brief period of 6 days in January of 2023, the panel membership, reserved for a practicing social work clinician, was vacant for nearly 4 years, until the position was filled on June 6th of this year. Per statute, the Attorney General is required to select a practicing social work clinician from a list of 3 names submitted by the Kentucky Board of Social Work. Following the retirement of the incumbent panel appointee in June 2020, the board did not send any recommendations for membership to the Attorney General until July of 2022. An appointee was selected by the Attorney General in January of 2023, but immediately resigned due to professional obligations. The Attorney General's office requested 3 nominations from the board in May of 2023. However, the position remained vacant until recently. Statute does not include language allowing either the panel or appointing authority to fill appointments if no nominations are made by the entity specified in statute. This can result in extended panel vacancies. These vacancies can cause the panel to be deprived of specialized knowledge or experience, such as the expertise of a social work clinician in this example. Matter for legislative consideration 3.A is that the General Assembly may wish to specify a procedure for filling the vacancy of a voting member of the Child Fatality and Near Fatality External Review Panel, and when it cannot be filled in the manner mandated by statute. As a result of Senate Bill 97 from 2022, statute requires the panel to determine which agency is responsible for implementing each recommendation and then forward the recommendation in writing to the responsible agency. The responsible agency is then required to respond within 90 days of receipt with a declaration of intent to implement or intent to not implement the recommendation. A statement of intent is required to include an explanation of how they will do so and an approximate time frame for implementation. A statement of intent to not implement the recommendation must include a detailed explanation of why. The panel has continued meeting its reporting requirements by determining and forwarding recommendations to responsible agencies from its most recent annual report. The panel's 2023 annual report included 25 recommendations, which were forwarded to recipient agencies by February 1st, 2023, which is the report's publication date. Agency notification and response requirements have existed for 2 of the panel's reports now. For both reports, agencies have not fulfilled their statutory requirements to adequately respond to the panel's recommendations. Only 48% of recommendations from the panel's 2022 report received appropriate agency responses by the deadline. Only 36% of recommendations from the panel's 2023 report received a required agency response by that deadline. In addition, the 2023 responses often did not include statutorily required elements, such as the clear statement of intent to implement the recommendation and a timeline for implementation, or a clear refusal to implement and an explanation of why the agency does not intend to do so. Of the 9 recommendations that did receive responses, only 3 received responses that included all elements required by statute. The panel received responses to 15 additional recommendations after the 90-day deadline. Table 3.1 in the report provides additional detail regarding the agencies that did or did not respond within that deadline. The panel may be able to improve its notification system to increase agency response rates and statutory compliance. For example, because notification letters are mailed physically, the panel does not know when notifications were received by each agency. Without that information, the panel cannot be certain of the date by which that 90 days within receipt deadline falls for each recipient agency. The panel could use certified mail or a similar service that allows for documentation of when material is received. Alternatively, the panel could establish a policy regarding a deadline for responses to determine when responses are late, provide a specific date for responses in the notification letter, and establish when panel staff should follow up on notifications. Recommendation 3.1 is that the panel should use a service like certified mail or adopt policies determining that 90-day response deadline by which agencies are required to have responded. In addition, it may be beneficial to send a standardized notification that includes spaces for agencies to provide all elements required by statute. The current form references the pages of the recommendation without stating the recommendation itself. The form requires agencies to seek out recommendations and create their own form. This requires additional time and effort from the agencies and results in a variety of responses from the agencies. While it is ultimately their responsibility to provide an adequate response, a standardized form could improve the quantity and quality of responses from agencies. Identifying the recommendations in the form would reduce the time needed to find them in the original report and not force the agency to develop its own template to respond with. The form should prompt the agency to indicate whether it will implement or reject the recommendations. For example, including checkboxes for implementing or rejecting those recommendations would prevent agencies from making vague statements that do not clearly indicate what they intend to do. Having a section to indicate how the agency will implement a recommendation or why it is rejecting the recommendation will make responses clearer, which will help the panel when it is considering how to draft future recommendations that are more likely to be accepted. Recommendation 3.2 is that the panel should update their notification letter format to include spaces for agencies to provide all of the required elements in their responses, such as clear intent to implement the recommendation, a timeline for implementation, and an explanation for declining to implement the recommendation if that's what they decide to do. Although the statutory framework discussed in the previous finding areas establishes legislative expectations related to the panel has wide discretion in developing its standard operating procedures. The panel set out to develop procedures for its operations soon after its inception and has since developed standard operating procedures related to its meetings, case referral, storage and review, and annual reports and recommendations. However, these procedures have not been formalized into written standard operating procedures. The benefits of developing and maintaining written procedures include establishing and communicating the components of internal control execution to staff, retaining organizational knowledge and mitigating the risks associated with having organizational knowledge limited to a few personnel, and communicating organizational knowledge as needed to external parties, such as external auditors or to new staff or panel members. Recommendation 3.3 is that the panel staff should develop written procedures for review and approval by the panel chair and members. The procedures should document processes like case reviews, the development of findings and recommendations, and the development of annual reports while complying with statutory reporting requirements. And that concludes our presentation. We'd be happy to answer any questions.
Thank you all for your presentation. I don't see any questions at this moment, but if you could just stick around as we hear the response from the Kentucky Child Fatality and Near Fatality External Review Panel. Thank you. At this time, we would invite Alicia Mahoney and Benjamin Harrison to come up and offer the, any response to the report. Please identify yourself for the record, and then you may proceed.
Good afternoon, Alicia Mahoney with the Justice Cabinet.
I'm Ben Harrison. I'm the Lewis County Attorney and also chair of the panel.
I'm Steve Shannon, served on the panel for about 8 years.
So we appreciate staff's recommendation. We take those very seriously. We always bring those up to the panel and have a discussion concerning those. So we do appreciate their recommendations, and we look forward to responding to those and possibly implementing those that we can. What I wanted to do today is present to you the report and go over some of the statistics and some of the findings that are in our report. On the first slide it's going to show the members of the panel. As you can see, there are several members appointed by various agencies, mostly from the Attorney General's office. I was appointed by the Secretary of State in April of this year, and Secretary of State's appointment, as you heard earlier, is the chair of the panel. So that's a list of professionals and very dedicated individuals, volunteers, that take a lot of time to review these cases. The panel meets once a month. Used to be quarterly, but because of the increase in cases that we've seen, the panel started moving to monthly meetings. And when did that start, Alicia? 2021. We've been doing monthly meetings. Generally take all afternoon reviewing these cases that are in front of the panel. So how the procedure works in the panel is that we review cases that are referred to us from the Department for Community-Based Services and Department of Public Health. DCBS conducts their own investigations into the fatality or near fatality and determines whether to substantiate abuse or neglect. The panel then conducts a retrospective review of these cases regardless of what DCBS says. Cases from the Department of Public Health are referred from the local child fatality review teams and the state sudden unexpected infant death team. These types of cases were either not reported to DCBS or were not accepted for investigation. The local review team consists of first responders and community partners who may have firsthand knowledge of the situation or the family or the event. In 2023, the panel reviewed 202 cases, and that comprised 68 fatalities and 134 near fatalities. 6 of those cases were referred from the Department of Public Health. So as part of our review process, we obtain information from a variety of sources, which may include autopsy reports, medical records, law enforcement records, and court records. So we have a huge amount of information that we take in on each of these cases, and staff then analyzes those and makes a presentation to us. Panel members determine key factors such as the type of case, which is a category, family characteristics that include risk factors, other qualifiers, and then we make a final decision on each case. All data that is in front of the panel we store in a data pool, which consists of 22 fields with over 200 data points. So as I said, there's a lot of information on each of these cases. So on our annual report, our report really promotes accountability, and we try not to blame one agency, one individual, one office in these reports. We make recommendations. We don't say this person's to blame or that person is to blame. By February 1st of each year, the panel is required to issue an annual report, which you have in front of you, consisting of case reviews, findings, and recommendations. The panel this year made 25 recommendations to 12 different agencies in the 2023 report. And so just wanted to go over those very quickly in that 2023 report. Since 2014, 75% of all cases reviewed by the panel were children 4 years of age or younger. The panel has continuously found that children in this age group are at a higher risk for a fatal or near-fatal event due to maltreatment. These findings are consistent with what we're seeing on the national level, and prevention efforts should continue to target families with younger children inside the home. So as far as trends in overdose and ingestion categorization, these remain the most common types of cases that the panel reviews. The majority of these cases were unintentional ingestions, which are potentially preventable with proper storage. The overdose rates seen by the panel are a small subset of a larger problem, and emergency department data received from the Kentucky Injury Prevention Research Center continue to show that case numbers of drug ingestions among children 4 years or younger occur at a much higher rate than the number reviewed by the panel. So again, on the trends there, you can see the total cases that the panel has reviewed and the total fatalities of those. Historically, the majority of overdose ingestion cases reviewed by the panel resulted in a near-fatal event. And like I said in the chart there, fatalities from ingestions have doubled since 2021. And you look there at 2019, there was just 1, and 2023 we're up to 8. So this would suggest to us that the potency of the drugs ingested are increasing and therefore causing a higher risk to children. So as far as the types of substances that are being ingested in these types of cases, it's, as you can see, they're kind of wide variety, and really not one stands out above the other than the opiates. As you can see, they account for 24%. So that, and then next to that would be cannabis or THC. So in referring to cannabis or THC containing products and the trends that we've seen in that category, we've seen a substantial increase in cannabis or THC containing products, resulting in a near fatal or even fatal event in children. And you necessarily wouldn't think that involving cannabis or THC. A similar trend can be seen when comparing emergency department data. With the exception of one panel case, all cases in this chart involve children 4 years of age or younger. And the American Academy of Pediatrics published a recent study demonstrating a consistent increase in pediatric edible cannabis exposures over the last 5 years, with the potential for significant toxicity. So in the section of our report concerning overdose and ingestion recommendations, we've made 7 recommendations regarding these types of cases. I'll just briefly go over those. The Interim Joint Committee on Families and Children should convene a work group with the Kentucky Board of Medical Licensure to discuss amending KRS 311.601 and requiring at least 1 hour of mandatory training be dedicated to educating all professionals providing in a medical assisted treatment setting. The Kentucky Board of Medical Licensure should provide additional continuing medical education on their website regarding the signs and symptoms of opioid ingestions in children and the administration of naloxone. The board should ensure proper training to medical marijuana prescribers regarding safe storage of medication and safe sleep. DCBS should develop a training specific to providers of medically assisted treatment regarding intake criteria and required information for mandatory reporting. Department of Public Health should partner with Kentucky Healthcare Systems to integrate a screening for medication or illicit substances, safe storage, and standard electronic health record intake for all pediatric encounters. And the Department of Public Health should do a public service campaign targeting retailers that distribute THC-containing products or kratom about safe storage and the danger of sleeping while under the influence of these products. And finally, DPS should amend the current regulation related to hemp-derived products to ensure the FDA warnings regarding child ingestions are clearly visible to consumers. So the next slide concerns Plan of Safe Care, and that is a federally mandated practice that is intended to address the needs of infants identified as being affected by or having withdrawal symptoms resulting from prenatal drug exposure. The goal is to ensure the health and safety of the infant, address the treatment needs of the parents, and support the family and caregivers. In fiscal year 2022, the panel reviewed 39 cases in which the index child was exposed to substances prenatally. This represented about 19% of all cases reviewed. Of the 39 substance-exposed infants, 12 presented with symptoms of withdrawal and were diagnosed with NAS, which is neonatal abstinence syndrome. So as you can see there in the PowerPoint slide, the number of there's so many acronyms in this. The number of, what is that, Alicia? Substance exposed infants, 12 presented with symptoms of withdrawal and were diagnosed with neonatal abstinence syndrome. So the next slide concerns in utero drug exposure type. You can see there, again, kind of all over the board. The children in panel cases were exposed to a variety of substances, both prescribed and illicit. Similar to the neonatal abstinence syndrome reporting registry, most infants were prenatally exposed to multiple substances. Nearly a third of these children were exposed to 3 or more. So when all types of opioid are combined, it accounts for 53.8% of all panel cases. 28.2% of substance-exposed infants were identified as lacking a comprehensive POSC. Of the 39 substance-exposed infants in neonatal abstinence syndrome cases, 18 were fatalities. Of those 18, 61.1 had unsafe sleep factors identified. So again, on this topic, data gathered from neonatal abstinence. Well, I just did that one, didn't I? Okay, all right, yeah. Okay, yeah. So this, I don't know that I have that slide in mind, but okay. You can just go on the next one there. So on Plan of Safe Care recommendations, we made 2 recommendations that are in our report that you can see. They're aimed at enhancing the capacity to implement the Plan of Safe Care as a tool to wrap services around substance-exposed infants, their parents, and caregivers. As a result, the panel formed a subcommittee consisting of members, subject matter experts, and panel staff. The subcommittee reviewed data from the NAS reporting registry, reviewed model practices from numerous other states, and attended a webinar by the National Center of Substance Abuse and Child Welfare. So in the topic of physical abuse, you can see the chart there and the trend where that's going. We reviewed more cases of physical abuse last year than ever before. 70% of all physical abuse cases reviewed by the panel were suspected to be caused by the child's biological parents. So some recommendations that we had in our report. The state currently requires multidisciplinary teams to review all child sexual abuse cases. Local MDTs review investigations, assess service delivery, and facilitate efficient and appropriate disposition of cases. So another topic that don't necessarily see in all jurisdictions in Kentucky is the Family Recovery Court. Two major systems that, of course, we've identified that interface most often with families at higher rates would be DCBS and the judicial system. As shown here, over half of all cases reviewed by the panel had previous court involvement. So again, over half of our cases had previous court involvement. Considering the high rates of court involvement, the panel has continued to advocate for full implementation of Family Recovery Court, that was formerly known as Family Drug Court. This assists families who are involved with the child welfare system due to substance abuse disorder and offers phases of treatment, substance use treatment, parenting education, and family therapy, individual therapy, and life skills training. Again, that's not, I would say Family Recovery Court is not something common that you'd see throughout the state. Do you know how many jurisdictions have that actually?
I know it's growing. I want to
Okay.
say around 6.
Okay, around six. So in the next slide there, comparison of co-occurring issues, all panel cases compared to cases with prior court history. You can see how high the prior court history is. When examining the highest occurring risk factors in these types of cases, which would be DCBS history, financial issues, mental health issues, domestic violence, criminal history, substance abuse, it is apparent they occur at a higher rate in those with prior court cases. And as we identified earlier, the judicial branch plays a crucial role in ensuring favorable outcomes for these families. So the next slide there identifies some DCBS issues, incidents, and their rate. In fiscal year 2022, 68% of all cases had a prior history with DCBS. So that's 68% had a prior history with DCBS. While prior history doesn't necessarily indicate some error with DCBS, it does require further exploration. So when opportunities for improvement are noted in the case reviews, the panel identifies them as DCBS issues. The panel found issues in 64.3% of all cases reviewed. This chart shows the rate and incidence at which these issues are identified. Gaps in contact was the most frequently identified issue. This includes providing face-to-face contacts, virtual contacts, and home visits. The second most commonly noted issue was screened-out referrals. So our next slide talks about screened-out referrals. The screening out of CPS referrals has been a long-standing concern. It's been identified several times by the panel. It is important to note that not all screened-out CPS referrals are problematic. This chart there on the screen compares high-risk factors found in panel cases with cases which have had prior referrals screened out. Cases with prior screened out referrals have higher risk factors compared to all panel cases. So, of course, the panel made several recommendations to DCBS. You can see them on the screen. And these would to improve their central intake system to address the screening out of referrals, specifically those made by professional reporting sources. Additionally, several recommendations regarding caseload information and twist improvements to better understand and address concerns identified by the panel. So in the section concerning firearm trends, you can see the fatalities and near fatalities from fiscal year 18 to 22 there on the screen. We've documented a significant overall increase in the number of firearm sustained injuries. In total, the panel has reviewed 72 firearm incidents in the last 5 years, including 48 fatalities and 24 near fatalities. Children involved in these near fatal cases are often left with lifelong and devastating injuries. So, concerning child access prevention laws, you can see there in the chart that accident cases in fiscal year 2022 accounted for 11, gunshot suicide 4, and gunshot homicide 3. Last year, the panel reviewed a total of 18 firearm-related injuries, 11 fatalities, and 7 near fatalities. 11 of the firearm injuries were accidental or unintentional. As I pointed out there, 4 were child suicides, 3 were homicides. Young children are more likely to be involved in these types of cases. The average age of the victim is 10. Unsafe storage practices were noted in 83% of all firearm cases reviewed by the panel. Next slide here talks about child suicides in Kentucky. You can see the numbers there from 2018 to 2022. Kind of stayed close to the same there through the years. The panel reviewed 7 cases involving youth suicides last year. 5 involved a fatality and 2 resulted in a near fatality. Suicides reviewed by the panel are a fraction of the total number of child suicides in Kentucky. This graph indicates the number of youth suicide deaths in the last 5 years. The distressing aspect of this data is the statewide incidence of child suicide in 2022 is almost 6 times the number of suicide deaths reviewed by the panel. So concerning youth suicide recommendation, you can see our recommendation that's in our report and there on the screen. For the past 4 years, the panel has recommended that the Department for Behavioral Health, Developmental, and Intellectual Disabilities develop a plan to implement a statewide utilization of the psychological autopsy. And such a psychological autopsy involves the reconstruction of events leading to the death and is known to give a comprehensive view of the influencing factors and can further support efforts in developing prevention strategies. It's conducted by trained professionals who are certified by the American Association of Suicidology. However, the Department for Behavioral Health Development and Intellectual Disabilities does not believe they are the appropriate agency to administer these efforts and offered to assess best practices in other states to develop an appropriate implementation proposal. So that leads us to questions, if anybody has any. I know that's a lot of information, but the panel and really staff has worked hard on this report to give to you, and they do that every year. It is some sobering information. So.
I think Senator Douglas has a question.
Yes, Mr. Chairman. Mr. Chairman, may I ask at least 2 questions?
Sure.
Okay, thank you, Mr. Chairman. If we could, let's go back to page number 4, where we're looking at trends. With overdose ingestion cases. One of the concerns, we take a look at the total cases of at least in 22 and 23, 63 and 55 respectively, and 7 and 8 in terms of total fatalities. Do you see that? Okay.
I think it's on the next slide.
That's in our population of 4.54 million people. Right?
Yeah.
Okay. No. Numbers mean something. I just want to make sure that we are giving our public an idea of some comparison,
Sure.
because the numbers sound horrible, and we've got to compare them. We got to compare them with something.
Sure.
My question, and it may be just a question I'm going to ask about 2 or 3 times. Do we specifically point out demographics contributors and geographical location contributors?
So in each panel case, there are several demographic things that are recorded. They are recorded geographically as well, correct?
In the annual report. Correct.
Yeah. So, and they are in the report there geographically, I think, by county. So, yeah, there are several things that we record in each of these cases.
Okay. I think these are some of the things that we need to talk about a little bit more instead of having them on the periphery. Mr. Chairman, may I ask my second question?
Sure.
Thank you, Mr. Chairman. If we go to page 5, where we look at overdose, ingestion, at the bottom of the page, we make some recommendations once again, and part of this is the provider and me, where we're increasing provider education. If I may, the fatalities that occur, do we find that they generally occur prior to or post provider contact? Or do we look at those?
Turn your microphone on, please.
These are the cases we receive, so the numbers may be larger for the whole state. So that's part of what this is. 63 out of 222. In terms of provider education, there are cases where kids consume their parents' Suboxone, which is typically a prescribed medication. So that case, I think provider education at least make sure the provider is communicating this needs to be stored in a safe way. I mean, we've had many cases where a toddler went through a mom's purse and found medication. Was it prescribed? Perhaps it was bought illegally. But we want to make sure if it has been prescribed, the ramifications of what can happen if kids consume this is dangerous.
Well, I just want to point out that in the training that we have, we do that.
Okay, good.
We do that. One of the things I'm most concerned about in the healthcare space. I'm sorry, Mr. Chairman, may I? One of my primary concerns in the healthcare space is that we don't talk enough about demographics and geographics. We don't talk enough about our biggest the biggest contributor to our poor healthcare outcomes, which is not our providers and not our healthcare system and not our ancillary personnel. It is patient compliance. And we are continually jumping on the backs of everyone other than
The
individual, right? I'm not pushing one way or the other. I'm simply saying we need to start having more conversation in the space of compliance, which is one of the reasons I feel, having been in medicine at least 40 years, we don't get as far as we'd like to get because we give a pass to those people who have to those personnels who have the greatest common denominator. You know, I've sat here and listened to experts talk about maternal mortality rates and how our healthcare system is so poor, and then I've gotten to them to admit that at least 93% of our maternal mortality is related to substance use disorder and not our healthcare system. So I think if we're really, even in this space here, if we're really going to get to the crux of some of the issues going on, the crux of the problems, we've got to start looking at that which is the greatest denominator. And I don't think it's our healthcare provider system. Thank you, Mr. Chairman.
Senator Carroll has a question.
Thank you, Mr. Chairman. In a couple different areas, Alicia, with the platform, after all these months, I still can't get to the cases. Is that an ongoing issue? Is it complicated? Or am I just, as Steve said, stupid?
Well, I have the same problem. So just reinforce my comment.
Okay.
I will say
it's very frustrating.
and I completely understand, which is one of the reasons we're moving to the new database system.
Okay, good.
And I will say, just yesterday they emailed us and the server was offline. The problem is our system was created in the 2013 SharePoint system. And the way our data tool was written in that system, you can no longer change it to make amendments to how we track our data. So what they're doing currently is merging that to a 2016 version. Then they're going to merge it to a 2019 version, all while we're building this whole new database. Okay. So it is constantly frustrating, and we're really hoping that the new database will solve these issues. And a lot of that is also that the majority of our members are not state employees, so therefore they have to get an AD account in the foster domain, and If you're not accessing the system every 30 days, you have to change. There's just a
And
plethora of reasons.
I can't tell you
and
the
I
number of times that
apologize.
I have tried and got frustrated and just stopped.
If you have your laptop, we can sit down after the meeting.
I was going to say, Senator, she came to my office and set it up for me, and I'm not touching it. So.
I didn't get that off.
Okay,
In fairness,
and
you're on before me, Steve.
you know, being a part of these meetings, and nothing really should surprise me from my time in law enforcement, but it does. And Senator Douglas is right, and there are common denominators with substance abuse in most of these cases at some level, and it's very evident as we review the cases. In looking at what the panel does, knowing now how it operates, and I know those that present the cases, they do a lot of research, and it's pretty insightful, the recommendations they make, and if there are missed opportunities, it's good work, and it seems that we're getting most of the documentation that we need from these cases, and that seems to be getting better. It's concerning about the lack of response when we review a case and there are recommendations. And for this to really be effective, it almost needs to go all the way down to the people that were involved. And there needs to be an after action, a review of the case with those involved at the local level as a result of what this team does. Due to the level of expertise on the team, it's valuable. It's valuable input. And there really needs, otherwise, if it's not getting back to the frontline officers, social workers, whoever, it's really not of any value other than statistics. And, we passed that law, but obviously that's not really, the law hasn't made much difference. What is the process? Is it part of your responsibility to send that information down and follow up? How is that working, and why aren't we getting feedback that we have asked for in the law?
Regarding the recommendations
Yes,
in the annual
yes.
report. Yeah, so after the report is finalized, I'll send out the recommendations with the cover letter that states the statute and where they can find their recommendations. But as far as me contacting the individuals, I'm not a panel member, so I can only act on panel guidance. And, as the staff pointed out, we don't have written policies. But obviously, if the chair says, hey, can we follow up on these, I would absolutely do that. But if I go outside of that, it could look like I'm violating that MOU between the cabinet because I'm a cabinet employee, and I could be impeding the operations of the panel. So, Ben and I have talked about this. We really do need to sit down and get some written policies in place. It would just really solve a lot of issues in that way.
And it's really tough having a bunch of volunteers, and I know how difficult it is doing these meetings monthly. I'm to the point it's hard to make them. Yeah. So that is a lot to put on a volunteer board. Do we need to reassess the structure of this? And this is important. And is it a matter of having additional staff to be able to do more of the administrative work? How can we feasibly make this happen to really make what's happening meaningful?
I was like, I can take on the part that I think we need more staff. I can say we are really pushing to meet that February 1st deadline with the annual report. A lot of the problem is we're not finishing the case reviews until the end of December. So therefore, we are rushing to analyze that data and then to research on what's best practice in certain areas. So having additional staff would absolutely, I think, benefit the panel. But again, I do kind of think first step is we really do need to sit down and think about policies and procedures and how to make it more effective. And then I'll pass it on to Ben.
I guess I would recommend that probably at some point this year there needs to be a meeting where everybody shows up and have these discussions and get a plan together to make all that happen.
Yeah.
If I may, one more, Mr.
And
Chair.
I'll answer that first question. You asked about how could we, is it possible that the panel is elevated within a cabinet structure, or does it need an executive director or an appointed lead of somehow? Alicia does a great job, right? But she doesn't have a title that has backing, and I think that's part of it. So if I'm in the executive branch where I was at one time, and I get an email from a staff person about this, it's not the same unless I get one from someone who's appointed, who this is their, executive director, whatever the title is. I think that may get more traction as well. I think that's part of the challenge that we send them out, and there's a lot of recommendations, right? But if you look at who responded, right, and who didn't, I think it's telling. So maybe somehow make it more visible. Can it become some other status within that cabinet? And it was assigned to that cabinet years ago. I mean, they didn't, when the first legislation was passed. So is it possible to do it that way? And that would make it more, it maybe more authority, more responsiveness from other entities.
Senator Carroll has another question.
Alicia, remind me with the process once we review a case, and there are cases that there are several missed opportunities. Remind me what happens with that review. How does it get down to, what level does it go to? Do the people involved get this information and what the panel has determined?
So the entities involved would not necessarily get a response back from the panel. Now, the missed opportunities, the way those are tracked, so every time we identify a missed opportunity, for example, and I don't want to pick on DCBS, but we'll say if there's a medical missed opportunity, so let's say there's a client who is not compliant with their MAT treatment, we would mark that as a missed opportunity. And then we'll go in and track that data of why it was a missed opportunity. So we'll say either the client was not compliant, drug screens were not, done properly by protocol, or there's a lack of sharing information. So we track that, and that is what helps formulate those recommendations at the end of the year. So at the end of the year, we pull all that data and really analyze it and go through why were these opportunities missed. But as far as reporting directly back to an agency, that's not something the panel's ever done. I will say for a little while, we were doing really good about if we see a case that's worked really well by DCBS, we were for a while trying to email the commissioner and the staff to say, send your frontline worker a thank you. This was a really well done job. Because for a while it was like we were only focusing on the negative aspect of it, and we didn't want to be perceived that way. But as far as contacting a local law enforcement agency and saying, why didn't you do this? We may have some off the books conversations, but we don't issue anything directly back to an investigating agency because it's all retrospective. So most of the time these cases have been closed for a year by the time we're looking at
And
it.
it's aggregated, right? It's
Yes.
all the data is aggregated.
Yes.
And it is retrospective, but having I remember being a brand new detective, and I remember the mistakes that I made, and those being pointed out made me a better detective. Yeah. So I think there is some value to that for those frontline people. Them understanding what the panel questioned, and don't know about the feasibility of that, but I do see some value in that.
Yeah.
Thank you. Thank you, Mr. Chairman, for the latitude.
You're welcome. Senator Thomas.
Thank you, Mr. Chair, and I'd like to direct my question to Steve. Steve, I've always felt that the essential purpose and value in data collection is to see where you've been and then where you're going. And I want to walk out of here today, knowing where we've been and where we're going. I mean, I recall when this panel and this body first got together under the first Governor Beshear, back in 2011, when I know the Herald Leader, anyway, my newspaper, did a series of reports about the alarming rate of child fatalities that took place across this state. And then Governor Steve Beshear acted and formed this panel to say we're going to study this every year and look at ways to reduce this. So I think I heard something in the report about there were 68 fatalities last year. I don't know what that is, but what were the number of fatalities for children in 2023, and how does it compare to the last previous years, 2018, 2017, 2016? Because I don't know that. I didn't get that information here. So what was the number in the past, last year, and how does that compare to previous years?
They're scurrying to find that. That's what we're running.
If we don't have it
But
today.
there's a couple pieces that we have to pay attention to. We've done a lot more cases, right? So that's going to increase the numbers across the board. And I think that's in terms of a walk away. When I started doing this, we met quarterly, and we would probably do 60, 70, 80 cases per year, right? Now we're doing 200 plus per year. So we're gathering more information. And the real challenge with activities like this is retrospective. You know, we're not being proactive necessarily. We're not identifying cases beforehand. But the real objective is to identify those trends and things that that frontline staff can then start paying attention to. So one, we're doing more cases, so we're getting more information. Two, we've really made a focus on plan of safe care. You know, let's make sure people have medications that it is taken. You know, I mean, one case, a kid climbed on top of the fridge and took his mom's medication. Maybe that's not a good place to store your medication, you know, on top of the fridge. And it just got a heads up from our friend from Jessamine County, you know, but let's figure those things out. But because of that, we've passed out, how many did we pass out?
4,000.
4,000 places to keep medications to individuals. We've done that. And that really is because we talked about it ourselves, that kids are accessing stuff they shouldn't be accessing, right? And parents say, okay, give me one of those boxes, we'll lock it up. We've talked about naloxone and make sure that's done correctly so kids don't get hold of that as well. You know, they shouldn't. Suboxone, clearly, kids get hold of that. Let's make sure it's taken care of. So that's a real tangible outcome. I wish I could tell you we're no longer the child fatality. We're just a near fatality. I wish I could tell you that, Senator. I don't think I'll ever be able to tell you that we eliminated child fatality in this state. But that's what we're doing. And, you know, I'm just one of the group. The people that are the real champions are the pediatric forensic medicine folks we have and the nurses that work with them. They do this every day, and they're trying to get to a system where can we identify those things that contribute to a child's death. And that's really what we're trying to do. I don't know if that's an answer to your question, but that's really what we're trying to get to a place and become better informed so people who interact with folks can be better informed about what things to pay attention to. I think we've done a great job with unsafe sleep. I have a daughter. You met my daughter. She's 25. No one told me about unsafe sleep, you know, and I was guilty of it. You know, I had one child to get middle of the night. I figured I could hold her in a recliner and turn on the VCR. And if she started wiggling, I'd hit rewind for a while, and then she'd be happy. We could all sleep. That's unsafe sleep. That was a really bad thing I did. We're talking more about that. People know more about that. And that's because we paid attention to it and saw it. Do you have those numbers?
We don't, Senator, so we'll
get them
those two
year to year. But I think it's to look at the numbers and the total cases and what's taking place, you know, and what's getting reported. Bad things are still happening to kids. We haven't stopped that. Not sure it's our mission, but we haven't stopped it.
Thank you for your presentation. Seeing no other questions, thank you all. Members, in your package, you'll see a copy of the report. At this time, I would entertain a motion. Well, we're going to do a roll call vote on accepting the report after we heard the panel's response. Madam Clerk, we need a motion probably.
Accept the report. Second.
We have a motion and a second. Madam Clerk, please call the roll.
Senator Rocky Adams, Senator Carroll,
Aye.
Senator Douglas,
Aye.
Senator Neal, Senator Nemus,
Aye.
Senator Thomas, Representative Blanton, Representative Burke, Representative Fleming, Representative Lockett,
Aye.
Representative Riley, Representative Sharp,
Aye.
Representative Stevenson, Representative Petrie, Vice Chair Howe, Co-Chair Storm,
Aye.
Co-Chair Bowling. Thank you.
We have a quorum. That report was unanimously accepted by this body, and I appreciate that. Members, in your folders, please note there's also a report of the Office of Broadband Development. I think there were some questions the last committee, and so that's in your packets as well. And then our next meeting is going to be August 15th. If there's no other business, I'd entertain a motion to adjourn. We are adjourned.
See you in the black box.
Yeah, you'll see.